Well, it's nice to see everybody, and welcome to those who are joining in from home. Take this off for a moment. Becky Bliss, who's a physical therapist with University of Missouri, does a lot of vestibular rehabilitation and concussion rehabilitation. Put these slides together, and I'll do my best to represent what she really wanted to share with folks. So I find a lot of this particularly interesting. I teach this to the athletic training students, and I'm sure by the time they graduate after their 2-year program with us, they think they've heard a lot about concussion, because I do have a passion for it, and I have a passion for keeping them on the cutting edge of evaluation and management. So I get really excited about it, and they just kind of roll their eyes every once in a while, but they bear with me. So today we're going to talk about some of the research, some of the more recent research in the areas of concussion management. And one of the things, some of this has been touched on a little bit already, but one of the things that we look at here is looking at concussion symptoms being more than just a symptom scale. And what we're really moving toward is this clinical profile, or you may have heard these referred to as trajectories. And this really will change how we manage concussions. And I've been preaching this to some of my students for a while, but I think now this is starting to take a little bit better shape in the literature, and it's becoming a bit more widespread of how we're going to look at concussions. But the idea of somebody with an anxiety or mood disorder is quite different, and how we're going to manage that person is really different than somebody who has cognitive or fatigue trajectory, and also very different from how we'd manage the ocular and vestibular trajectories. So somebody who's having difficulty with memory and with recall is quite different than somebody who has dizziness when they're in a loud, noisy, high movement environment. So if we can separate those two and manage them appropriately, we can get much better outcomes, I think. Migraine is certainly its own beast. And we look at those a little bit differently. The sleep trajectory probably isn't going to show up for a few days. These other things we can begin to tease out a little earlier, usually within the first 3 days, 3 to 5 days for sure. We know what track they're going down. Sleep is a little bit different, and it may take a little longer for that trajectory to really show its face. And then one of the things we also want to look at that we've pulled in as another important symptom is somebody with neck pain. So the person who's telling you that they have a headache, we begin to get into some of these functional questions, like, how bad is this headache? Tell me a little bit more about it. Where is it? When do you get it? And that can all tease into this. Somebody who has headache at the end of the day after they've been in classes or been busy reading and watching screens, that's telling me that this, and the headache is behind their eyes, that's telling me this is probably more of the ocular motor trajectory. Somebody who tells me that their headache is on one side, probably telling me that that's more migraine. Somebody who tells me their headache starts in the back of their head and it feels like somebody comes up and squeezes their brain, but it starts back here, that's making me think there's some neck associated injury here. So am I going to treat all of those patients the same? Nope. And I want the person who is treating them to know what their symptoms are, when they show up, and where they show up. And so if we can do that, if we can begin to tease some of that out, I think we can get people on to a better path towards recovery. It really does open the door for a multidisciplinary approach, which is something I think across healthcare we're pushing for. And we've looked at some of these other tools that are used, this dizziness handicap inventory, the vestibular ocular motor screen, the VOMS tool, I think is how many ATs are in the room? How many of you are using a VOMS in your concussion rehab or concussion eval? So I'm teaching our students, just put that in there. That's in there. That's going with their scat. Maybe not the day of, probably not the day of, but second, third day, 24 hours later, 48 hours later, 36 hours later, somewhere in there. Let's find a way to check this, because it is relatively common. many times pre-existing. So this, everybody can see that one, right? No, I know. I had another slide where I had split that up, but really this is looking at their symptoms, and they just in here of it's none, mild, moderate, and severe. So we've looked at symptom checklists before, and this is same thing, just looking at it. The questions are worded a little bit differently. So if you come across this Contos article from 2020, same idea. They categorize the questions. So what I can see here is that it's the number one is feeling sad, headache when you wake up, difficulty or headache when looking at a phone or computer screen, dizziness when you move your head, difficulty turning off your thoughts, headache with nausea or upset stomach. So, you know, that dizziness question, man, I love that one. Like, when are you dizzy? Tell me about it. Is it all the time? Is it when you move your head suddenly? Really changes how we're going to treat that symptom. But what we can do with this symptom checklist then is they split out that there are certain questions that are associated with the different the trajectories. And so we can look at how they score those, and they get a raw score, and then they get averaged out. So if we look at this patient, we know that they have a pretty strong anxiety and mood profile. And if that was pre-existing, this concussion may exacerbate that. But it also is going to change how I ask this patient questions. If they have a high level of anxiety, I'm not going to talk to them every third period of the day about what their symptoms are, because I'm going to try to not stir up their anxiety. I am going to involve the people who are taking care of them for that anxiety in advance, before their concussion. And it's something that I'm going to talk with the treating physician about what we see. It gives us something too to talk about with them. You can see this person has the neck modifier, nothing. So the vestibular profile is pretty low. The migraine profile is absent. So it helps us not spend a lot of time on things that may not help this patient, but focus on things that may help them. So when we begin to say this person has a concussion, I don't think I'll get to feel the same way about the word concussion as I do about shin splints. Hate that phrase because I think it's Latin for my leg hurts below my knee. That's all I know about it. So when I'm in the future me talks about concussion, I'm going to think about, okay, this person has a concussion, but they're following the vestibular ocular trajectory, or they're following the sleep trajectory, or they're following the migraine and sleep trajectory. So maybe I can be more precise in how I describe their concussion, and then I can be more precise in how we manage that concussion. So that's what we're looking for here. It helps us pick out the right treatment for the right patient. Or it can. That's the alleged thing. And then we have this other study looking at dual task assessment. We know that there is a twofold increase in risk of musculoskeletal injury in people who have had concussion and return to sport. Why do we see that? Well, it might be in what we do in how we bring people back. So we think about, we give them relative rest with some aerobic activity, and then until their symptoms are back to their baseline or dissipated. And then as we begin their return to play, we have them do activity. And then we have them activity while they're trying to think about what they're supposed to do. We gradually increase their cognitive load, and then we add in contact. So it's this progression that's nice and slow, but is it really challenging enough to retrain their ability to do multiple things at one time? A lot of the tests that are used to determine if somebody's ready to go back are measuring one thing at a time. So this dual task is looking at two things at one time. And this is looking at a single task gait test time. If we look over here, and then a dual task tandem gait, and dual cat, then they're looking at their accuracy. So a single task might be single leg balance with their eyes closed. How good are they with that? Dual task is asking them to do something else while they do that. So if I could get one person from each table to stand up for me, and you can tag your friend and ask them to do this for you. So we're going to get into a tandem stance. So heel to toe in a straight line, hands on your hips. Go ahead and close your eyes and watch your friends from your table while they're standing there with in their tandem stance with their eyes closed. And I want you to think about the 5th number of your mobile phone number. Did you see how they started to sway? And those of you are thinking, what is the 5th number? What's my area code again? And we're on. What if I'd have asked you for your coworker's number? We don't know anybody's numbers anymore, so that really would have thrown you off. But that's a very simple task. Can you think and do something at the same time? You were just trying to balance. What if we had you trying to do a tandem gait and you're trying to do this? What is what's 7 times 3? Uh-oh, we're back. You said there would be no math. But we're doing this, and I'm trying to get you to do simple math. What happens if I have you doing this backwards and you're trying to do simple math? Or you're trying to step over something? Or what we see more in sport is you're trying to react to what's in front of you. And we'll talk about that here in a little bit. But what we know is if we ask people to do 2 things at once, that really taxes the entire system, and we begin to see deficits in their performance. We're going to come back to that reaction time here in a minute. I'm a big fan of the vestibular ocular motor screen. What we do with this one, there are a few pieces to this. One thing is that we ask for people to do what's a smooth pursuit. So hold their finger about, we'll just go, should be 3 feet, and keeping their head still. They're just gonna follow this as it goes across. And I'm watching their eyes, and do their eyes track smoothly? Do they go all the way? Do they overshoot? Right? I think I'm getting this one. Actually, I'm going to hold them right here. I'm going to give you 2 targets. Can you follow those back and forth? And then can you follow them up and down? So we're watching how well the eyes can track. We can, so that ability to shift view, and I'm just talking myself in circles here for this one. And then there is the ability to focus on an object right here and turn your head. And does it stay in focus, or do you begin to lose it? And then I also want to know if you can go up and down. And can you stabilize that image in front of you? And then yes. So the question was, how quickly do we see these signs? You might see them a little bit earlier, but if the person's telling you that they have this crazy dizziness, I'm probably not doing this acutely, but certainly within 3 days, I'm probably going to be looking at this kind of test, vestibular ocular motor screen. And what we're looking for, does this make their symptoms worse? And for an adult, we ask them to grade this. For a child, we have to do this a little differently. So their goal here was, instead of your headache was a 2, we start to do this. If it goes to a 3, but if it jumps to a 6, that's certainly getting my attention. So an increase of 1 doesn't get too much. But when we're dealing with in here, we're looking at a 5 to 9-year-old pediatric patient. We have to ask them, does this seem to, is your head hurt more? Does this make your stomach hurt? Does this make you feel sick? Does it make you feel like you're spinning? So we have to just change the language that we use, but they were able to, with this study, concussed patients were more likely to have an increase in symptoms compared to someone without a concussion. So it's a nice tool. And that the other things that we do with this is near point convergence, where we have them bring their finger in towards, or a pen or pencil, where they're bringing that towards their nose, and how closely can they come before they start to see two. And 6 centimeters is a normal distance. Some people get here and go, whoa, forget that. Like, I'm done. They're already getting cross-eyed when they get in here. So, and others can bring it all the way in. So, and then there's, just as long as we're talking about it, the last piece of it is, can they stand here and watch their thumb and pivot? Now, when I'm doing this, looking at you, this busy background, this could be enough to trigger a lot of folks. This, against this plain wall, it's a much quieter environment. So if you have in your clinic at the school, you don't have a blank wall. I know we try to fill walls up with things, right? But think about having a blank wall for people who, with this busy environment, just makes them flare a little bit. So place where we're not telling them to close their eyes necessarily, but someplace they can look that's just not so busy. So this tool, you know, if we're gonna manage this concussion, you know, I always think of the students who, the adjustments we make for students in the hallway, sometimes they get to leave early or late, so they're not in the busy hallway environment. That's this kind of thing, where all of that noise coming past them just can't do it. But without all those other people in the hallway's manageable for them. So this is, if you have a student who's giving you that complaint, you know they have this vestibular ocular motor deficit, and some simple training, there's simple exercises that can be done to progress them right along. We tell people if someone sprains an ankle, they may be able to walk, but they probably can't run. And so we don't start them running. We get them walking well, then we slowly progress them into running and jumping and cutting. But same thing with a concussion, particularly this vestibular ocular motor trajectory. Let's bring them back in slowly. That same type of rehabilitation can be quite helpful. So, and that's a very different dizziness than some of the stuff that's associated perhaps with neck. So we'll just manage them a little bit differently. And now we get to come back to reaction time. So this is one that when we think of people going back to sport, we think this is really important. There are a lot of ways to test this. None of them are particularly simple. There is one simple one where they took a hockey stick, cut the blade of it off, and then just put a weight on it, and they have the person hold it, and they drop it and then catch it again, and you're seeing how quickly. So that's pretty low tech, but it is their ability to react to it. There are other things. Some of the computerized testing gives us a reaction time measurement. The Dynavision is a really high tech where they see a light and then have to reach out and tap this board. I don't have one of those in my building. So that's something that most people are going to use. We can look at some of the sway balance. Their ability to react and recover when there's a loss of balance, or this limits of stability testing. So there are a lot of things out there, and you start to say, why would this be important? And I think two things. One is these people trying to return to sport, but the other thing is many of them trying to return to driving. They're going to be on the same roads as we are. So understanding the importance of reaction time, pretty important for my safety is the way I look at this. We can see a reduction in reaction time up 60 days post-injury. And there's Gary Wilkerson's an athletic trainer at University of Tennessee at Chattanooga. has done some really interesting research in retraining recovery time, or retraining this reaction time. And he talked about it as being a visual motor reaction, or visual motor system, that when you see it and you process it, and then it turns into a motor response. And people who had injuries had deficits here. And they took two groups, and he had one go through training and one not. And the training group, you could see their injury rates, because if you get injured, your biggest predictor of, that's the biggest predictor of re-injury. But they had them coming up, and this group that did the training, all of a sudden, 0 injuries once they finished their training. And this group kept going up. So when I saw that graph, I was like, wow, he's on to something. And he made it pretty simple. He showed this, 5 chevrons or arrows, and you had to look at the one in the middle and react to what it is. So if we did that instead of visual, if we did that auditory, if I give you an odd number, raise your right hand. And if I give you an even number, raise your left hand. So simple enough, right? 7. Those are some slow hands, aren't they? I don't know if it's the right left thing or if it's the odd even thing. Yeah, we'll just leave them. So 3, 8, 4. Okay. Now let's change this. And if it's an even number, go lift your hand on that side, because I'm pointing here. If I say an even number, go opposite me. And if I say an odd number, go the same way as I do. So 4, 8, 8, 3, 3, 7, 2. So you're catching on there. Now we're going to go, so we can make this bigger. So pick the second number that I give you. Go the opposite. What are we doing opposite for? We're using second number, odd or even. Even is opposite, odd's the same. 74, 97, 73. That little bit, did you feel yourself hesitate? And that's just trying to hear it and then process that. And then you had to make a decision. Am I going the same way or the opposite way? And then I have to make a motion. We think about what we're asking drivers. Let's leave it that. We can talk about drivers, but also athletes are trying to make a decision of what they're supposed to do. Am I coming right at you? I have to make a decision now on if you're going to step aside or I'm going to step aside. And I recognize that by the way you move. But if I'm concussed and I process this slowly, I'm not going to make the right call. I'm going to either misinterpret your movement or I'm just going to make my decision too late. And so the idea of this reaction time being depressed for up to 2 months, we know we can bring it back. And for somebody who's really anxious to work on their craft of sport, this is why they're coming to school some days, right? I mean, we all know a few kids like that on a day or two where they just as soon stay home, but they show up because there's a game. Can we look and we find a way to do this training? And so if you, I can't remember where that was published, Wilkerson's research, but for those of you in ATs who are looking at trying to train this, he did it real low tech. He did it with a PowerPoint. So some of the solutions we have for reaction time are really high tech and unattainable. And he said, everybody yells at us about high tech. So here, I did it on a PowerPoint. Like, he's one of the smartest people I've ever met in my life. If you ever hear him talking at a meeting, go listen to him. He talks real fast, but he spits out so much good information, your head will spin. But it is this idea of training reaction time. And if you're thinking about people you care about who are going back to driving, we might want to make sure their reaction time is where it needs to be. in addition to going back to sport. So the idea of reaction time is something we don't train a lot. We don't talk about a lot. I think it's like the next frontier of concussion recovery is getting us back to this. And perhaps this can be the answer to reducing that risk of musculoskeletal injury. So, you know, something to think about. And then the other thing we know is that multimodal individual rehabilitation is better than a cookie cutter approach. I know that's not a big surprise to everybody in this room, but if we can do sub-threshold aerobic exercise that does not flare their symptoms, they get better. Exercise increases the brain-derived neurotrophic factor, or BDNF, and this is growth factor in the brain, and it helps us reorganize and stimulate those pathways. So sub-threshold exercise helps the brain recover from concussive injury. That little shake that happens to the brain that can cause some shearing, that can disrupt everything that we have going on, this BDNF can help us recover. What we've found is if that exercise threshold, level is too low, if you're going at about 50% of the recommended heart rate zone, you're not going to see any result. We know if you go at 100% or 110%, you're not going to see a good result. You'll see a result, but it will not be good. So we were always pushing somewhere in the 70 to 80% range. But what Letty has found in his studies is that we can go at 80, 90% of that heart rate zone. So below, we can be just below where we flare the symptoms. This is going to, then these people get better and it doesn't flare their symptoms. So we can be, you can be 70 to 90% of that sub-threshold heart rate zone. But if you're going to go at really low at 50%, you're not going to make a difference. So it has to be a little bit higher. And then looking at this, symptoms lasting more than 2 weeks, who get individually tailored programs, reduction in symptoms 3 times more likely to have returned to sport by 8 weeks. So for those people who are dragging on, the tincture of time probably isn't so helpful for us anymore, that we can't just wait things out because they're going down a trajectory that, like vestibular oculomotor dysfunction, doesn't recover with just time. We have to retrain the system. And so recognizing that, getting them better, and then we turn the corner. Remember a few years ago when we had people who had patients who had recovered from concussion or perhaps not recovered, come up and tell their story, for those of you who've been at these. And there were a couple of those stories that when we heard them, we were like, holy moly, this person just needs to see this kind of specialist and they'll be better. And so that's the part that I think we've made progress in the last 5-6 years. I think we're making progress. And so just keeping everybody aware of it, that there are these trajectories, and so our rehab needs to fit those trajectories. Whoops. Got a little bit itchy there. So this is looking, this study by Reed was actually a systematic review and meta-analysis. And so here they are, their effective exercise on symptom scores. And if you see this diamond in the middle, this black diamond at the bottom, that's the meta-analysis where it favors the exercise for reducing symptom scores. Man, they're touchy here. And then this one is exercise on days to symptom recovery and return to activity. There's some overlap there. It does cross that middle line, but overall it does tend to favor exercise. And if we look, see if I can do this without going over here. Man. So on that figure 4 on that top, for you, that'd be the top right corner. Yep. And that's looking at tailored multimodal management versus kind kind of the cookie cutter approach. Again, then that's looking at return to activity, and that tends to favor the individual approach. And then you can see that on that lower right-hand corner, that is about symptom score, and clearly their symptoms are better when we tailor this to the individual. So including exercise, particularly helpful for symptoms and returning, and then multimodal, individual, tailored approach, again, better. I again can liken this to an ankle sprain. They are different, and if we give everybody the same cookie cutter rehabilitation, yeah, they're going to get better. But if I can dig in and find out what's best for you or for you or for you or your particular injury, you're probably going to get better sooner. So being able to recognize those. Now we can move to the next slide. Come on now. I really have worked with the computer before. I know it's hard to believe, and I do this for a living. And this is looking at the concussion and psychological effects update. And we certainly do see changes in mood and behavior. And there are worsening symptoms of depression, anxiety, attention deficit, sure. And I think if we know the people who have these symptoms in advance, people who had them, their pre-existing condition, we need to loop the professionals who are working with them into this care early. And the earlier we do that, we can probably see a better outcome. Certainly, psychological care, not my wheelhouse. This is not what I do. It's not my specialty, but I'm really good at dialing a phone and calling the people who can step in and help for this one. And so I think that's where we are, knowing our patients, knowing the people we're taking care of. Do they have these pre-existing conditions? And if they do, let's get the person taking care of them looped in earlier rather than later. And I think that can help manage the cases, particularly for these students who have this as a pre-existing condition. And then this one is looking at returning to school. And we're looking at a young age group. So age 5 to 7 is on the left, 5 and 8 to 12 is in the middle, 13 to 18 is on the right there. And this early return to school, and this means like at day 3, that was considered an early return to school. So for those 5 to 7-year-olds, that did not help them. Their symptoms tended to increase by the end of 2 weeks. So these were all people who had presented to the emergency department. And then there was a follow-up 2 weeks later to look at their symptoms. So as you can see in that 5 to 7-year-old, that line tends to go up. So they saw an increase in their symptom score. But look at the 8 to 12 and then 13 to 18 years old. For those people, if they went back to school early at day 3, by 2 weeks, their symptoms tended to be better. So we can see that line goes down. So they were endorsing fewer symptoms at a lower rate. So that whole returning to school, being around their people, their social group really made a difference. Let them get back into normal activity. I think that idea of if they are home and are they, as Dr. Daniel said, are they sleeping all day? I mean, what happens to you when you have a surprise day off and it's rainy like this? You know, if it's a nice day, we're all out doing things. But if you have a day off and you nap, you're tired, you don't even know you're tired, but we're all a little fatigued at some point. So now you have permission to sleep. And so that can mix things up too. So bringing people back to school sooner than later. Now, surely somebody who has had significant trauma, they were in a car accident and had a traumatic head injury, little different. That is different than most of the sport-related concussions that we see. But this idea of letting people get back to activity as they tolerate it, something we really should consider. Do we still need to make accommodations where maybe they're not in school, in class every period? Sure, absolutely. But I think as a community, we can work on that to make this whole outcome just a little bit better. I'd rather have somebody in school and in class half the time than off on their own trying to manage for themselves. So having that school community around, I think, can be profoundly helpful for a lot of things. And it also helps us keep an eye on these folks as they work toward recovery. One would think. What do we do? Repeat these? So that takes us to the end of these slides. And I'd ask if there were any questions. Yes. Sure. There's a great test out there. It's called the Buffalo concussion treadmill test. And they also have a version of it for the bike. And I would take somebody through that and then set their exercise threshold based on what they do there. And that whole idea is just increasing. It's a slow ramp up of intensity, and we're watching their perceived exertion and their symptoms. And if they can max out, then maybe it tells us that concussion might be something else. In which case, is it vestibular oculomotor? Because it's not the physiologic concussion is there. But I think that's the best way to determine where they should be exercising. And I'm sorry, I didn't repeat that question. It was for those of you playing at home. The question was, how do you determine the exercise heart rate threshold? So, yes. Sure. So the question was for 10 to 11-year-old students who have a concussion coming back day after the concussion or within 24 hours, and perhaps engaging in physical education courses and recess and a lot of physical activity. So not everybody should be back in 24, but people should probably be back by 3 days, not 24 hours, I should say, but certainly by 72 hours could be back in there. If they're still having symptoms, the physical activity, if it's going to flare their symptoms, I think, I still kind of go with that. Let's just take it easy for 24 to maybe 48 hours, and then let's start to go. But I might have them in classes more than doing physical exertion at that point.
Thank you, Kitty. Updates and research is always greatly appreciated. I'll grab this here. On behalf of the Brain Injury Association, we have a gift for you.